Well, welcome to Grand Rounds. Apologies for those. I was on video earlier, but turns out my internet's unstable. So we are going to do audio only for a moment. I'm so happy that was able to make this. I'm actually on the process of moving across the country, but this is my final Grand Rounds and sort of my final act and opportunity to engage in chiefly activities for what has been a wonderful year. I have the distinct pleasure and honor of introducing several of my colleagues today. I believe for order of operations, we are going to start today with the Paul Beeson Award, which will be presented by doctors Jessica Pinto and Sayuli Bidet, who are my fantastic co-chiefs at the VA. So maybe should I turn it over to you, and then we can jump back to...
We can't hear anything. Is it our turn? Or is David still talking? All right, we're gonna take over.
Okay, great. Well, thank you everyone for joining us this morning, or afternoon, I should say. We're very excited.
Can you all see our screen? Awesome. So my name is Sayuli Bidet.
And I'm Jessica Pinto.
And we're the VA Inpatient Chiefs for the 24-25 academic year. And we're going to be announcing the winner of the Paul B. Beeson Award today. For those of you who don't know, Dr. Paul B. Beeson was a distinguished physician at the Seattle VA Medical Center from 1974 to 1979. He was widely celebrated for his teaching skills. The Beeson Award is an award that is presented in his honor annually by the internal medicine residents to recognize outstanding clinical teaching, by a faculty member who exemplifies scholarliness, humility, compassion, and integrity. Before we announce the winner today, we also just want to acknowledge and congratulate our 32 amazing nominees for this award. We had many nominees this year with great comments from the residents. So we just want to congratulate all of you and thank you for all of those who were able to show up today.
And so now for the exciting part, the winner of the 2025 Paul B. Beeson Award is Dr. Vincent Reichel. Dr. Vincent Reichel is an assistant professor in the UW Division of General Internal Medicine. He earned his medical degree at Weill Cornell Medical College and then joined us at the University of Washington for his internal medicine residency training and subsequently served as an amazing VA chief resident for quality improvement and patient safety. Today, he is currently an assistant professor and hospitalist at the VA Puget Sound and serves as the pathway director for the internal medicine clinician educator pathway.
So Dr. Reichel, if you are able, we would love for you to unmute and turn on your camera and say a couple of words if you have any.
Hello, thank you so much. Can you hear me? Yeah, thank you so much. This is so wonderful. It's so meaningful to come from the residents and to be part of this community. I'm so humbled and appreciative.
Thanks so much, Vince, and thank you everyone who's joined and here to congratulate him as well. I'm going to hand it over to our lovely co-chiefs for the rest of today's Grand Rounds.
Thank you so much for that. Congratulations, Vince. Well deserved. I now have the once again distinct honor and pleasure to follow in the footsteps of my colleague, Dr. Lazarevic-Fogelquist, who was my co-resident and then co-chief resident at Montlake this year. He was kind enough to introduce me at my Grand Rounds 2 weeks ago, and I will now do my best to do as well as he did. But Dr. Lazarevic-Fogelquist received his undergraduate bachelor's degree in biology and anthropology from McGill University. He then moved to Seattle for several years before attending the University of Washington School of Medicine for his MD, where he later completed his residency in internal medicine. And he is, at least for the next few hours, one of the chief medical residents for the internal medicine residency program based at the University of Washington Montlake. After the end of this year, he will be remaining on as a UW Montlake hospitalist. On a personal note, I have had the unique privilege of sharing this year, as well as the preceding years of training with my friend, Adrian. I do not say this lightly, but it has been probably one of the biggest honors of the year to get to become such a close friend with him. It is one of the reasons that makes my move away from the state so deeply sad, but I am so happy to have this friendship and to continue to foster it over the following years. With that, I would like to turn it over to Dr. Lazarevic-Fogelquist for his grand rounds. Oh, and if I could add a note to please place all questions in the chat for our future chief residents, Doctors Weaver and Chen, to MC the Q&A at the end. Thanks, everyone.
Thanks, David, for that introduction. And David is calling from a coffee shop in Spokane, where he is completing his move to Michigan, where he will be deeply missed by me and by many others. Thanks for that introduction, David. And yeah, so as in my waning hours as chief resident, I have the great pleasure of presenting grand rounds. My grand rounds today is Dr. Chatbot, or How I Learned to Worry a Little Less and Warily Accept the AI Revolution, which a very small N survey told me not so many people got the reference to Stanley Kubrick's Dr. Strangelove, but I hope there are some folks out in the audience who appreciated the homage. And it feels relevant in the topic I'm going to be discussing today, which is AI in clinical medicine. And disclosures and caveats, I have no financial relationships to disclose. No one is paying me to speak on AI today. I'm definitely not an expert in this field, and honestly, this topic came out of my own ignorance and the realization that this is coming. This is happening for all of us. It's here now. And there was a medical student on the wards here who was actively using AI in their day-to-day workflows in ways that I didn't fully understand, and that prompted my interest in this topic. And so I'm hoping to share some of what I have learned in my explorations these last few months with you all. I think my family will tell you that I am something of a Luddite and not prone to the adoption of emerging technologies, but I'm working on it. And so I will say that this talk is not intended as a deep dive into any particular aspect, but more sort of a broad overview of some of the interesting ways in which AI tools are being implemented in clinical medicine, with me as kind of an amateur but very enthusiastic tour guide. I'll also do my best to avoid mentioning any specific commercially available products, unless unavoidable because of study design. Okay. So our outline for today, we're going to do some definitions and a timeline of developments. I'm going to present on some of the domains of clinical use. I'm going to talk about some of the limitations and challenges that the present and future of AI in clinical medicine hold, and then leave you with some best practices and further resources for those interested. So given that this is a talk about artificial intelligence, I thought that I would start by letting AI speak for itself. So I asked ChatGPT to provide some definitions, some self-definitions as to what artificial intelligence is. So AI is the field of computer science that focuses on creating computer systems or machines that are capable of performing tasks that have historically relied on the human brain to be able to complete, such as learning, reasoning, problem solving, and critical decision making. A large language model is a subtype of an AI model that takes vast quantities of text data to generate human-like, contextually aware outputs, initially only of text, but increasingly of other media, and that are capable of learning to recognize and create patterns from the training data. And then GPT is a specific type of a large language model that was developed by OpenAI, most notably with the recent release of GPT-4, which generates human-like text data by predicting the next word in a sequence. And it will come up later that the training corpus of GPT is not publicly available knowledge, but likely includes a vast quantity of the internet and a large swath of human-generated information, of text based information, but we don't entirely know what has been in the training corpus. Some further definitions: machine learning is a subset of artificial intelligence that focuses on the process of using data and algorithms to make predictions. So the goal of machine learning models is to make these decisions purely from information that is gleaned from the data rather than external user inputs. And then neural networks of various kinds are modeled on the way that we think human brains work to try to perform more complex reasoning tasks, to recognize greater degrees of hierarchical patterns, and to produce more complicated outputs. And then deep learning is a subset of machine learning that uses these neural networks that have many layers to perform ever more complex pattern and representational tasks. So with that, I want to transition to a timeline that starts in 1950. Alan Turing published Computers and Intelligence and proposed the Turing test as an assessment of machine intelligence. But the field of AI study really kicked off in 1956 with the Dartmouth Summer Research Project on AI, which was a bringing together of some of the leading computer science minds of the time who established this as a formal field of study. Then through the 60s and 70s, there were the early development of some natural language processing chatbots, as well as some rules-based clinical decision support systems. So you can see Myson, M-Myson, and Internist. But these didn't reach wide distribution. Then in 2007, IBM developed Watson, which was a question answering system that used natural language processing to develop probabilistic answers, which won Jeopardy in 2011. And then in 2017, Watson was used to identify pathologically altered RNA binding proteins in ALS. And then in 2020, Google's DeepMind solved the protein folding problem in that it was capable of predicting the 3D structure of an amino acid sequence. Sorry, the 3D structure of a protein from its amino acid sequence, which was a remarkable development. And then since then, we have seen a rapid expansion of a variety of AI-powered tools across various domains of much of society, but in medicine specifically, research and clinical applications. And then I just want to point out that March 14, 2023, OpenAI released ChatGPT-4, which had markedly increased generative capacity and multimedia generative capacity compared to its predecessors. So using data from the FDA, I just wanted to show the growth in the number of FDA-approved devices that are using artificial intelligence or machine learning. So you can see through 2015, almost none, and then the rapid expansion, and the pie chart on the right breaks those tools down by medical specialty. You can see the majority coming from the fields of radiology, but increasingly cardiology, neurology, and increasingly many others. So like I said at the beginning, I think the reason this topic was of interest to me is because the revolution is here. This is happening. And so the American Medical Association surveyed almost 1,200 US physicians and showed that year-over-year growth in the use of AI tools in clinical contexts almost doubled. So approximately a third of doctors were using them in 2023. And then as of November 2024, almost two-thirds of doctors surveyed were using some form of AI tool in their day-to-day workflows. And you can see on the right, many of the use cases that saw the most growth had to do with tools around documentation particularly, but others as well. And we'll spend, okay, we will transition now to talk about some of those use cases. Again, this is not an exhaustive list of all the ways in which AI is being used in clinical medicine, but are some of the ways that I thought were particularly interesting to me as someone engaged in inpatient medicine and as a budding hospitalist. So I think we all know and feel that the burden of documentation for physicians is large. And a 2016 study found that physicians in ambulatory practices are spending 2 hours doing EHR desk work for every hour that they spend in direct face-to-face interactions with patients, as well as spending an additional 2 hours on documentation outside of office hours. I can't see anybody, but I am imagining that there are folks in the audience who are maybe nodding their heads or feeling a twinge of recognition at the ways in which the EHR, while meant to be a tool that is a tool that is meant to make our lives easier, also adds its own burdens. And so time spent in the EHR has also been shown to contribute to physician burnout, which I think many of us feel. I also want to point out just that all the non-study images in this presentation were generated in ChatGPT. So I think we're hoping to go from this to this. So we are increasingly seeing the use of AI-assisted dictation or ambient technologies that being implemented across many different practice settings. And there is evidence to suggest that the implementation of these AI tools is effective in reducing the amount of time the physicians are spending on documentation. Although the effects of those reductions in the burden of documentation on physician burnout and the time that they spend on work outside of office hours are a little less clear. So hoping to go to something more like this. So a study from Stanford, this is Ma et al., studied 45 physicians across 8 ambulatory disciplines, and they found that the incorporation of ambient technology reduced documentation time as well as time spent in the EHR, although you'll note that these seem to be fairly modest reductions in the amount of time spent per note, and that there was a widely heterogeneous distribution of the effect of, or the net benefit or the net effect. This second study is by Tierney and colleagues who looked at a year's worth of data after the implementation of ambient technologies in ambulatory practice and found, again, that there was a greater degree of accrued benefit to people who used the ambient technology more. They had a greater reduction in their time spent on documentation than those who did not. And also that the decrease in time spent on documentation increased with time. So I think the more familiar we become with using these technologies, the more that we integrate them into our workflows, hopefully we do see more benefit with time. And so there are at least 2 sides in that outpatient or clinical encounter. And so I wanted to take a moment to just think about patient perspectives on ambient AI tools. And I will say that having taken my dog to the veterinary office and my son to the pediatrician's office and having both of those providers use ambient technology, I felt the difference. It did feel as though the provider was much more engaged with me and my son or my dog, whichever I was with, in a way that changed and improved my experience. And so this is from Tierney et al. Again at Kaiser, showing that for the most part, patients were describing a positive change in their interaction with physicians, and that the physician was able to spend more time engaging with them directly rather than spending time on documentation during the visit. I think the other aspect that's going to be relevant on the patient side, among many, is I think many of us are seeing these kinds of headlines, and I suspect that we're going to see more. And so it's not only us on the physician side who have access to these AI tools. And that does mean that we're going to be encountering patients who have a larger wealth of AI-informed information at their disposal. And I hesitate to say that will always be good information. And so I think we are all going to be, it's going to be incumbent on us to have it be part of our process of communicating with patients more who have this information available to them. Because I think these are the stories that get told, and the places where the AI is recommending inappropriate treatments or inappropriate medications, inappropriate testing are the ones that aren't necessarily making it into the news. One other kind of corollary or piece of this is the presence or the use of AI-powered chatbots. And so kind of there are studies that are showing that that virtual chatbots available 24/7 to patients have positive impacts on the uptake of a variety of health promoting behaviors. Ones that were specifically studied are smoking cessation, reduction in substance use, and improving medication adherence. So I think just remembering, I'm going to spend most of my presentation talking about impacts on the physician side, but I think remembering that patients have access to these tools too, and that patient-facing AI tools are going to be increasingly widespread. So we've talked about reducing documentation in the actual visit. And I wanted to focus on the ways in which AI tools are maybe going to change how we approach chart review and chart synthesis. So I think we all know that much of the clinically relevant data is stored in the EHR in ways that aren't easily accessible. So in unstructured, free text data that can be hard to find. So for example, a patient subjectively reporting bilateral ankle swelling that doesn't make it into any diagnosis code, that doesn't make it into anything that is carried forward. And so that can be lost. And so there are increasingly AI-powered tools that are capable of extracting and synthesizing these kinds of unstructured free text data and then turning those into synthesizing that data and turning them into, for example, risk stratification scores, evidence of adverse drug events, identification of risk factors such as risky behaviors, smoking, substance use, et cetera, and detection of medication discrepancies between prescriptions at discharge and the discharge documentation. So I think the totality of these is that there are going to increasingly be AI-powered tools that are capable of rapidly reviewing and synthesizing a large quantity of unstructured data from patient charts, synthesizing those, and hopefully assisting us in the earlier identification of new worsening disease processes that are going to allow us to intervene earlier. So as kind of an inpatient analogy to that, we have been using, in the inpatient side, using early warning systems and rapid response systems that have been implemented widely, although a 2021 Cochrane review did find that it is unclear that these interventions are actually impacting in-hospital mortality, unplanned ICU transfers, or length of stay, which was a piece of novel information to me, I will say, in the review for this presentation. But it does seem that the incorporation of AI and machine learning powered predictive tools is allowing for earlier detection of clinical deterioration. And so this is from a systematic review and meta-analysis by Yuan and colleagues that showed that pairing AI chart tools that are monitoring some subset of chart available parameters, vital signs, labs, et cetera, allowed for the earlier identification of patients who are at risk of clinical deterioration with impacts on in-hospital mortality and hospital length of stay. And you can see that there is a signal, but not significant decrease in the risk of ICU transfer. So I think seeing, I know, for example, that University of Colorado Anschutz is using a variety of AI-powered tools in conjunction with something called their virtual ICU to try to monitor patients more closely, identify patients at risk of clinical deterioration, and implement physician-powered interventions to try to prevent poor patient outcomes. And I think their data is similar to this in showing improvement. So I wanted to talk also about some of the ways in which we are using AI tools for their diagnostic and predictive powers as well. So Skynet the diagnostician. Some of the ways that we have seen AI tools be effective in making diagnoses or predicting outcomes is, for example, screening for pulmonary malignancy on chest CTs, identifying breast cancers on digital mammography, identifying large vessel occlusions on head CT, improving the identification of shockable rhythms by automated external defibrillators, differentiating COVID-19 from community-acquired pneumonia and other pathologies on chest CTs, and notably predict on the basis of clinical parameters or laboratory parameters rather, the patients who are likely to have favorable versus unfavorable early outcomes of stroke treatment with thrombolysis. So putting these together, the incorporation of diagnostic and predictive capabilities with augmented or automated triage pathways hopefully will allow us to identify earlier and intervene earlier on patients who are deteriorating clinically. So one study that I found notable, Hassan and colleagues found that pairing AI detection of large vessel occlusion on head CT with automated activation of the stroke team at a comprehensive stroke center decreased time to transfer for patients who ultimately went on to receive thrombectomy. And so meaningfully changing the time to intervention. I wonder if some of you, like me, hearing these are feeling that we might be at risk of losing our jobs. So I wanted to take a particular example from my own patient care. So this is a patient that I took care of on Swing. So Swing here at Montlake about a year and a half ago, who posed a diagnostic challenge for the clinical team and see how we performed compared to an AI-powered diagnostic tool. So the prompt, this is to please provide a differential diagnosis and suggest the next steps in treatment and workup for a 30-year-old female patient with a history of MPGN, immunosuppressed on prednisone and mycophenolate, presenting with 2 weeks of fever after recent travel to South America and Japan, with vitals notable for tachycardia and fever, an unremarkable physical exam, and labs notable for elevated inflammatory markers and an AKI. So I put that prompt into Open Evidence, which suggested that the most likely diagnoses were dengue fever or other arboreal illnesses, arboviral illnesses rather, CMV infection or reactivation, EBV infection, drug-induced fever, idiosyncratic drug reaction, community-acquired influenza or other upper respiratory viral infection, and then suggested that the most important can't miss diagnoses were HLH, sepsis, and disseminated fungal infections such as histoplasmosis. Recommended that the key additional history and workup was to take a detailed history, to perform some targeted workup for sepsis, as well as some specific workup for particular pathogens, dengue, CMV, EBV, and histoplasma, and then to obtain further laboratory studies along with the possibility of a bone marrow biopsy concerned about HLH. I will say that this was a case that, as I said, presented diagnostic challenge for several days and ended up being a case that I presented at Chief of Medicine several months ago that was HLH secondary to disseminated histoplasmosis. So I think this was notable for me in that those things were both on my initial differential. I think I had them ordered similarly to Open Evidence, but that this tool may be something that I don't know if it would have meaningfully altered the clinical care that I provided in the moment, but I can see that in other difficult cases where I'm feeling stuck, this might be a tool that I would turn to help guide next steps in workup if I'm feeling as though I don't have an obvious next place to go. And so I think I wanted to put together an idea of how our workflows might be in the present or in the near future as we incorporate these tools for diagnosis, tools for prognosis, and tools, patient-facing tools for triage and interaction. So, for example, a patient who has a concerning lesion sends a picture of it to an AI-powered triage that then raises that to the level of a dermatologist or a pathologist for review. Their AI-powered tools then schedule a patient for diagnostic workup. That diagnostic workup, it undergoes, they have a biopsy. The biopsy is then reviewed by AI-augmented tools with the assistance of a pathologist. It reports it as a malignancy. The AI tools for prognosis, for treatment prediction and prognosis assist in deciding on a treatment pathway and coming up with risk factors and likely outcome. And then after treatment, the AI is assisting in ongoing monitoring for both treatment toxicities and risk of recurrence. So I think we can see that for an individual patient along the life cycle or the natural course of a disease process, there are so many different touch points where the way that we provide care might be meaningfully altered by incorporation of these tools. That doesn't, I think, even that leads us to thinking about what the future looks like. And so I think combining the AI tools I've been discussing up until now with big data, multi-omic data, along with the enormous capacity of and processing power that's being brought to bear by AI tools in novel drug design and identifying therapeutic targets, as well as trying to understand the genome and protein level underpinnings of human disease, are going to have enormous implications for our future ability to deliver highly individually tailored precision medicine, the frontiers of which I think we are really just on the cusp of exploring. And so I spoke earlier about AlphaFold, Google DeepMind's AlphaFold, and this is a predicted structure of a protein from its a 3D predicted structure of a protein from its amino acid sequence, which has enormous implications for the design of therapeutics going forward. That's the end of the portion that I wanted to spend talking about the incorporation of these tools into our clinical workflows. And I think I run the risk of making it sound utopic, that we're going to have all these tools that at the snap of our fingers are helping us diagnose patients, come up with predictions for treatment outcomes, risk factors that contribute to the development of disease, and then provide highly tailored treatment recommendations to patients. But as with any new technology, the AI is not without its limitations and its challenges, and I wanted to address a couple of them here. So the first are hallucinations and distortions. So to define a hallucination is the generation of plausible, coherent sounding, but factually inaccurate or entirely fabricated information in response to a question. And so this can range from recommending an incorrect but appropriate sounding medication dosage to, for example, the complete fabrication of journal articles or resources when a query is made for a set of references. And so as I mentioned at the very top of the presentation, the training corpus of these commercially publicly available LLMs, many of which are being integrated into EHRs, include a lot of data that is neither reputable nor factually accurate. And so I think we run the risk of, if we take on faith the outputs that we receive from AI, it's a little bit like asking the family member that you're not the most excited to see at Thanksgiving dinner, who, yes, they've read every medical textbook that there is, but they also spend a lot of time in some of the weirder, darker corners of the internet. And so if you were asking that person for medical advice, you would take the answer that they gave you with a hefty grain of salt. The picture here is just an example of a variety of kind of factually or hallucinations. So I asked ChatGPT to produce a 5-minute chalk talk for medical students on the diagnosis and management of atrial fibrillation with RVR. This came out of a seminar that I went to at SGIM this year, where we did the same and noticed that the output was kind of completely inaccurate. So in the initial iteration of that, ChatGPT recommended alpha blockers for the treatment of AFib with RVR. In my example that I produced, it just doesn't even mention rate control as a strategy for the treatment of RVR. So like I said, I would continue to take answers and outputs that you're receiving with a large pile of salt. The next set of concerns that I wanted to address are privacy and ethical considerations. So most commercially available AIs do not make their training algorithms available for public scrutiny, and the ways in which the models are training themselves mean that these are a black box. We can't peer inside to see how what algorithms are taking the inputs that we provide and then leading to the outputs that we receive. And so there is no transparency or ability to provide oversight or public scrutiny at the algorithmic level. The other issue is that using, for example, ChatGPT, it's not a HIPAA compliant tool. And because of the large quantity of data that is available to it, even if you upload de-identified clinical information, you run the risk of GPT being able to take that de-identified data in conjunction with other publicly available data and re-identify patient data, which is both a privacy violation and also like a HIPAA, a breach of HIPAA compliance. And so I think being extremely careful about the ways in which we use these tools with mindfulness to how it impacts our patients' privacy is going to be very important. And then the last challenge I wanted to point to is that even though they have the possibility of seeming like neutral arbiters, the large language models are trained on materials that we as humans have generated. And so they reflect the social biases that are present in our societies, and they risk both perpetuating and exacerbating these biases in their outputs. So there are multiple examples of the ways in which ChatGPT's outputs recreate social biases that exist, and some that I've highlighted here. So models trained on clinical notes were substantially worse at predicting rates of readmission for Black patients. Many commercial prediction algorithms that were used in multiple healthcare systems were using healthcare expenditure as a proxy of health status, which then meant that it underestimated risk of health risks for patients who historically have not had access to healthcare. And so it's the ways in which we are blind to our own biases are captured and encoded in the systems that we create. And then if we take on faith that those systems are neutral, are unbiased, we run the risk of perpetuating those biases. And increasingly, the more content is generated by large language models and AI tools, those biases become ever more entrenched. And so one other way that I think it's important to think about this is at the level of early medical trainees, in that the more that we're using these tools to create clinical vignettes, learning materials, it is important for us to know the ways in which they are biased so that we can try to de-bias them as we're creating new content for learners. So a fairly seminal study by Travis Sack and colleagues showed that they asked ChatGPT-4 to create clinical vignettes for medical students to learn from. And you can see here that ChatGPT has wildly misestimated or under or overestimated the prevalence of a variety of diseases based on patients' demographic data, and its outputs reflected that misestimation. And so as it was creating content for students, it was providing inaccurate representations and creating illness scripts that are demographically based. Which runs the risk of, again, just perpetuating and more deeply entrenching these biases in our systems of medical education and our systems of the provision of health care. Just another example of this, ChatGPT-4 was much less likely to recommend a referral for advanced imaging studies on the basis of the same clinical presentation for Black patients rather than patients of other ethnicities. And I think that's not shocking for those of us who know anything about the history of medicine in this country, but it does make it really important that we think very carefully about how we use these tools and the ways in which we rely on them to predict or provide recommendations for diagnosis and treatment. I like this graphic that was shared with me by Dr. Karen Segerson here at UW that comes from a paper by Leslie and colleagues during COVID-19, where we live in a world where we know that there is unequal access to healthcare, that our healthcare systems are biased. We then encode those biases in the data that we provide to the large language models so that they are non-representative samples, which then encode those biases in the data itself. We then create AI tools that are trained on these biased data that then provide biased outputs, which the more that we use, the more that the circle continues. I think two things that I want to really raise here are one, that any degree of using AI tools that are based on patient information. So the more that we're incorporating patient level data into AI tools, I think it's really important to think about the ways in which patients whose data is being used are or not accruing benefit from the tools that we design. So if you have a subset of the population whose data is being scoured to train models, but then they actually never receive the benefit of the incorporation of those models into clinical practice, that is an outcome that we don't want, and risks exacerbating the kinds of healthcare inequities that we know exist in our system. The other thing I think that as someone who works now and for the foreseeable future will continue to work in a large academic center that's likely to be at the forefront of the incorporation of these kinds of tools into clinical spaces, is that we want to be very mindful of the ways in which the unequal incorporation of these tools risks exacerbating health inequities in the rural and urban divide, rich and poor spaces, and so not as I will talk about in my thoughts about best practices, that thinking about equitable application of tools across populations and patients is essential as we move forward into this new world. So I wanted to leave you with a few more things, including some thoughts about best practices for the use of AI tools. So these are adapted from a few different places, the AMA, the Society of General Internal Medicine. And so I think first is just in thinking about patient privacy as a priority, that we need to be using HIPAA-compliant closed-circuit AI tools for clinical decision rather than inputting patient data into publicly available tools, even if we think that we've adequately de-identified that data. So I know, for example, the VA has a newly incorporated AI tools that are closed circuit so that they exist only within the context of the VA and they're not connected to any outside organization. I think the next is transparency in healthcare, so that we need to disclose that we are using, for example, ambient tools and provide options for patients to opt out from their use, as well as the option for patients to not have their data collected for the training of further models. As I mentioned, these tools are at risk of creating factually inaccurate or erroneous recommendations. And so I think we can't remove ourselves from the clinical decision-making space and rely on fully automated systems. I think maintaining human-in-the-loop clinical decision systems where we are continually verifying the outputs of generative AI is going to remain important for the foreseeable future. And that, I think, it comes in two forms. One is, I think you can ask ChatGPT or open evidence to explain clinical reasoning for decisions and to provide direct references for the decision, for the outputs that it's providing. And so I think maintaining an index of suspicion for factual inaccuracies and then actually using the primary data to confirm the outputs remains important. And then I think lastly, the two things that I want to talk about are thinking about the ways in which we as individuals have a responsibility to advocate for unbiased and equitable application of these tools. And so demanding transparency into the algorithms and training data that are representative and inclusive so that they don't further encode bias. And then advocating for equitable access to the kinds of augmented healthcare systems that we are moving towards so that the benefits of these new technologies accrue equitably across our patient populations. The very last thing, I started by asking ChatGPT to define itself. And I wanted to leave you with ChatGPT's thoughts about some of the anticipated advances and key challenges ahead. I think this is a one-side summary of my entire presentation, some of the ways in which AI tools are going to be used across a variety of clinical contexts, some of the ways in which those tools have challenges that are built in that we need to work to mitigate. But I was heartened to see that ChatGPT doesn't think it's coming for my job and that these are going to be augmentative tools rather than tools that replace us, and that the human doctor-patient relationship and is going to remain central to the practice of medicine going forward, even as we have ever more powerful tools at our disposal. I just wanted to point folks to a few more things that I have found helpful as I've been going through this. I think the New England Journal of Medicine AI and the NEJM AI podcast have been an interesting way to hear clinicians and non-clinicians who are deeply involved in the development of AI tools talk about various aspects of it. Has been very helpful. Dr. Karen Segerson gave a grand rounds about a month ago on some of the specifics about the ways AI is being used in medical education here in our own institution. And then there's information about UW Medicine policies around the use of AI, as well as some of the tools that are currently being piloted at UW Medicine on the internet, which I recommend. And so with that, I wanted to say in closing that I return to the analogy of my title. So thinking back to Kubrick and Dr. Strangelove, I think we're standing on the cusp of a really remarkable and transformative technological advance, the implications of which for society at large, but also our day-to-day workflows and the practice of clinical medicine are not totally clear. So the future is somewhat uncertain, and I think we all have a responsibility to try to be more familiar with the present so that we can help shape the future to be more positive for ourselves and for our patients. And so with that, I'll close. I wanted to say thank you to Dr. Scott Hagan at the VA, Dr. Karen Segerson here at UW, and Dr. Paul Sutton here at UW, who all helped guide my thinking about this along the way. And then, as this is my very last official act as a chief resident here for the internal medicine residency program, I want to say an enormous thank you to the program, to the residents, to everyone who has made this year truly wonderful, to my co-chief, David, who is, as I said, one of my, as he said and as I said, one of my best friends and someone who I will miss dearly. And lastly, to all of you who attended today, thank you so much. This has been an amazing year, and I appreciate all of you.
Thank you so much, Adrian. That was a really excellent talk on, something that I think will become increasingly important for clinicians to understand. We're going to move on to the Q&A session. So encourage folks to ask questions in the chat. We have had a few so far. So your first question is that with all that you've learned about AI in preparing for this talk and throughout your clinical experience, how do you plan to or not plan to incorporate AI into your future practice?
Yeah, thank you for that question. The first thing that the way that I'm using this now, and for the most part, is actually generating teaching materials. So, like for example, asking ChatGPT to using best practices for NBME style board questions, please create a list of 20 NBME board questions that I can then use with the medical students. So I think I'm not comfortable at this point using AI tools to do what I showed with the patient presentation to assist my clinical decision making. I don't feel confident, and I'm still much more comfortable using UpToDate than I am ChatGPT or open evidence, really. But I do think that kind of quickly generating teaching materials is a way that I have started incorporating it. I think that going forward, I can see a world in which this is just much more part of well, I definitely can see a world where going forward, this is much more a part of my day-to-day workflows in clinical spaces. But as of right now, it's mainly been in helping create teaching materials.
Amazing. Yeah. Really liked also what you were saying about keeping the human in the loop too, double checking, everything that it outputs. And then Trish, we saw that you had unmuted yourself.
Yes, it's
Yeah.
true. I'm taking the chair's prerogative again to turn on my camera and ask a question. But first, I want to say thank you to Adrian and to David for all that they've done this year as chief residents. I only got to fully experience it for the second half of the year, and it's been outstanding. One comment, I feel like only in Seattle would ChatGPT generate a patient who looks like a backpacker and not really much like a patient in that picture. But my question for you, Adrian, is I think there are people who are early adopters who are diving into using AI, and then there are a bunch of, as you described yourself, Luddites who are less likely to dive in. And I wondered if you could share, like, how do people start to dip their toes in the water? I think that is kind of like what's the entry point for people, and maybe it's not in the clinical spaces or even the education spaces. Maybe it's in the life spaces. So, what's your advice on that?
Um, that's such a great question. So I think this described me. I went to SGIM 2 months ago and was part of an AI panel, or went to a seminar that was a panel on AI in clinical medicine and medical education. And I was the person in my small group who they said, so of course, all of you are using AI daily. And I said, I have actually never opened ChatGPT. This will be my very first time. To which the person running the seminar looked at me like I was a madman. And so I think in the intervening time, one of the ways that I have found it particularly helpful is if I have a specific clinical question, not generating a differential diagnosis and treatment plan or anything, but like help me understand some specific pathology, some specific disease process. I will now go to open evidence and ask that question, and more specifically, ask for the references that are being used to support the output. So I'm trying to think of a recent example. I don't have one off the top of my head, but like something like I don't fully understand this disease process. Can you tell me what's going on here, and then point me in the direction of primary literature that I can use to understand further. I think that's an easy way to it's just quicker, faster, and more powerful than, for example, UpToDate to answer those kinds of clinical questions. And one of the people who ran the seminar at SGIM that I liked what they said about this was, I think we run the risk of replacing our own critical thought, our own brains, and turning them off if we just start asking questions of the tool. And so instead of asking a question for just an answer, I think what she said was you should ask a question in a way that leaves you with more questions. And so I think that's how I've been trying to approach it, is like, if I'm going to be using the tool, I should walk away with more questions than maybe an answer to my original question, but then more questions.
Thank you. And I'll go away so you can answer the other question.
Okay, we have a question in the chat here. Have any of our medical societies or organizations issued guidelines for the ethical use of AI or LLMs?
So I found a couple in doing this research. The Society of General Internal Medicine and the AMA both have position papers about the use of AI. Excuse me, I would say they don't rise exactly to the level of guidelines, but they are some best principles and recommendations for individuals and more for institutions about the way that they use these tools. So I would point people to the AMA and to the Society of General Internal Medicine.
Great. And then a second question has there been any consensus about where the liability falls when medical mistakes are made by AI or people using AI assistants? God,
it's such a challenging question. And to my to the best of my knowledge, consensus, no. I think this is something that is a pretty active area of discussion. But yeah, there's nothing that approaches a consensus that I found.
Mhm.
Okay. There's a question about de-identification. And so how much de-identification is necessary to prevent an LML from re-identifying the patient, or if that's known? Example says, or here it says, could you change the age by 2 to 3 years? Is that enough to feel like you're, not going to be violating HIPAA?
The honest answer is that I don't have a blanket answer to what is an excellent question. And it's honestly my lack of certainty about that is why I would hesitate to put really any patient-specific information into a publicly available LLM. So I think, the things that are obvious, right? Patient name, of sort of the obvious things to remove, we would all be doing. But I like in the case of my patient, a 30-year-old woman with these diseases who recently traveled, to my mind, those are in the context of a tool that has access to the entire swath of the internet. Those are potentially things that could be used in conjunction to identify the patient. And so I think we need to I would err very heavily on the side of not putting any patient-specific information into publicly available large language models. Yeah.
You have some messages, some congrats, excellent talk. Do you have thoughts about how we balance the potential benefits of AI with the enormous energy consumption and threats to the environment?
That is a huge and fascinating question. I think I think this lies somewhat outside of the realm of the specific talk about AI in medicine, but I do want to acknowledge that the degree of processing power that's required and the energy consumption that underlies that is enormous and threatening our already endangered planet. I don't have a specific answer for how to think about balancing those things. One would hope that we are in some degree able to innovate our way out of our current challenges and that some of that might be done with the assistance of AI tools. But I do think that changing global consumption patterns and the ways that we approach the pillaging of our natural environment is a huge and ongoing societal level problem.
Cool. And then we have another question here, kind of about the political climate. If political changes delete information like DEI or vaccine information from sites like the CDC, what is the risk of LLM reinforcing these changes?
If I understand the question correctly, and then forgive me if I don't, I think if the LLMs are, and the answer is I don't totally know how these sources are being ranked hierarchically in terms of their sort of value, right? If the CDC is, for example, a higher value source to ChatGPT than Reddit, then it actually probably matters even more that changes are happening at the level of the CDC website, for example. But I would say that broadly, anytime that we are making changes to publicly available information that have the potential to harm folks, like I would say removal of DEI focused information and recommendations for vaccines, the LLMs are going to be scraping those data, incorporating them into their pattern recognitions. And so I think it probably will bias the tools more towards, for example, not recommending vaccines.
We have a comment that on the question of liability, when an error is found to have occurred, My mind goes to one of my favorite quotations from Andy Dolan, JD, former counselor for the WSMA and many Washington state clinicians. In quotes, remember, a lawsuit is like a birthday party. You invite everybody. And then he says, I do miss Andy's contributions to many medical discussions.
Yeah. And then some other comments of very nice discussions and excellent topic. We are at time here, 1 o'clock. So just thank you, Adrian, for really bringing this topic and teaching me a lot about, ethically how to use this and where that information is coming from, how to use it with trainees and just my own clinical practice. So it's really informative for me. Thanks so much.
Thanks, everyone.
Thanks, Adrian.